Cool. Well, thank you so much, Luke, for taking the time to chat with me. Based off our first conversation, I think you have a lot of awesome resources and just things to share, about the work you're doing, your own life. So I'm just going to give you a little bit of time to introduce yourself, name, pronouns, what you're doing, how you identify. Yeah, so let us know.
Sure, thanks, Taylor. So my name is Luke Grandis. My pronouns are he, him, or they, them. And I'm an upstate lead organizer for Vocal New York, as well as a consultant for Next Distro. So Vocal New York is a statewide grassroots organization fighting to end the drug war and homelessness and mass incarceration and to end AIDS. And we do that by building the political power by people impacted by those issues. So we have a statewide users union made up of people who are currently using drugs, people who are former drug users, people who have been impacted by overdose. And we work on drug policy and passing that into law to change and save New Yorkers' lives. So right now we're working on passing the Safer Consumption Services Act to legalize overdose prevention centers statewide, and working on decriminalizing buprenorphine, specifically this legislative session. Last year, we passed a bill for MAT in prisons and jails. We got syringes decriminalized finally after a decade-long fight. We also removed a prior auth requirement for people on MAT who have Medicaid. As years ago, they only removed it for people with private insurance. And we didn't want any more two-tier, another version of two-tier care in the system. So a lot of it is really campaigns led by people who use drugs and people who have experience with drug use and or are in recovery or remission, people who have survived overdoses and people who have lost loved ones to an overdose, leading really strong statewide campaigns to pass this legislation to restore the dignity and personal autonomy of drug users in New York State and people impacted by drug use.
Wow, so you are doing quite a lot. And one thing I will add, and you probably already know this, but as of today when we're talking, and today is May 9th, because this will most likely be coming out, in the next few months or so, the SCSA made it onto the last health committee agenda in the assembly, which is super exciting. So that's big kudos to you and everybody else who called, bugged everybody to get it all done. So it's just amazing. And I'm so glad that, our paths crossed. I know more about Vocal, and so glad that you're involved with the folks at Next Distro as well, because obviously they're increasing access all over the country and doing amazing work. So I think one of the things that struck me when we had our initial conversation is just how much passion you have around MAT and the lack of access and just what needs to be done there. So I'd love if you can kind of just, jump in and tell us, like, what does MAT kind of look like right now in the state of New York, or to whatever extent you can speak to it, and where do we need to go with it?
Yeah, absolutely. I think access to MAT and or lack thereof and all of the barriers to access is something that we don't talk about enough when we speak about the overdose crisis and the drug poisoning crisis. And so I really feel that we desperately need to shift a focus into increasing access. Over the last 8+ years that I've been in remission from opioid dependency, and I've struggled to access my MAT almost the entire time. I dealt with only having access to cash providers for a long time, even with health insurance, having a vehicle, having knowledge about how to navigate the system. And often, anytime I think about the fact that I have barriers myself as the privileged college-educated person, it constantly reveals just how much more challenging it's going to be for so many other people in the world who don't have those privileges. And so methadone for buprenorphine, things like Suboxone, Subutex, etc., we really need to be able to remove the X waiver so that we shouldn't need, providers shouldn't need this exorbitant extra training to be able to prescribe these meds, right? You don't need any extra training to prescribe the actual same medication if it's for pain management, right? But you need extra education to prescribe it for opioid use dependency reasons. But ultimately, there's just not enough access. There's, I think, often a misconception that access to MAT is really that it's there, that there's steady, reliable access, and it's really not the case. Often there's providers that are supposed to be accepting patients, but either due to the cap that they have or really stringent barriers to care where people won't be able to get on MAT there if they take any other controlled substances, right? Especially any other controlled substance that would be concerning to the medical provider. So if they're taking a benzodiazepine of any kind, like Xanax or Valium or any Ativan, something like that will almost immediately disqualify someone from being able to get buprenorphine. And while we understand like concern about the respiratory system, there are so much evidence showing that these are not the wildly death risks that people, assume it to be in those situations or imply that it is. And often I think we really need to shift to a reality of understanding that the risk of someone not getting their bupe is far more of a risk than having them combine that bupe with other drugs, right? That might also suppress the respiratory system. I think constantly we're over obsessing about these quote unquote risks that are really driven by stigma and shame and not really driven by true concern for people's well-being, because then we would be just as freaked out about the idea of them not having access to buprenorphine at all, right? And then if you look at methadone, something that's been a huge staple in keeping folks who use drugs alive for decades now, extremely amazing medication as well, long, slow released, fully acting opioid agonist in the body, and the barriers to methadone care are just exorbitant. I've recently been on methadone for the last little about almost a year now in my life after being on bupe for the 7 years before that, and having to go at least 6 days a week every day to a clinic to access your medication when you begin, at least when you start, and then needing to prove your abstinence over time, right? And not that you should need to be abstinent in the first place, but even if you show up at that clinic and you've been abstinent for 5 years, you still need to start over at day one. The quote unquote benefit of the doubt that you're given is that you can't be trusted, which unfortunately just seems to be the lack of benefit of the doubt, or so to speak, that really all people impacted by drug use are given or not given. But so I really think that when it comes to methadone, a lot of times we look at these systems and we say, okay, we need to make, like, yes, obviously we need more funding, we need fully staffed clinics, everything like that, but also let's pause, look at that situation and say, do we need these clinics in the first place? Because should we actually be requiring people to come into a clinic for this medication? Or instead of fully funding clinics and pumping up the infrastructure of the in-person clinic, should we just be acknowledging the real research evidence-based data we do have access to, that we could very much be sending people home with their prescriptions the same way we do if they're on methadone for pain management. There is no reason that someone being given a 30-day prescription of methadone for pain management is not going to be at a similar risk for overdose if they can combine it with only other drugs. And simply because they're not documented as a person who uses drugs on paper does not mean that they're not going to potentially combine those. We can never fully control, we're never going to control other people's behavior. Drug use is a part of life, and we really need to find ways to put an end to medical providers thinking that they can intervene in those processes by creating barriers that only set people up for failure. Asking someone to come in somewhere 6 days a week when they need to travel an hour plus each way is completely inhumane and very much setting that person up for looking for an easier alternative locally. And so if the powers that be really want people to stop using drugs in that way, then they need to give them the medication that allows them to do that, right? But in reality of supporting everyone's goals and personal autonomy, we really just need to provide MAT access as broadly as anything else and respond to this overdose crisis as the crisis it is, which would mean providing MAT at a far, far more accessible way.
Absolutely. And it's so interesting. Every time I have conversations with people, it's like when we bring up the barriers, it never ceases to amaze me that people don't quite understand that setting people up for failure, like you said, like creating these barriers always has the opposite of the intended effect, right? Like when you look at prohibition and when you look at even just over the weekend, somebody posted an article about, yes, they're going to ban menthol cigarettes, and yes, this is going to be great, and they're doing it under the guise of this being a benefit to the Black community, when that's actually going to have the opposite of the intended effect, right? So there's this very interesting narrative that kind of gets like interwoven that like, yes, we're doing these things and we're providing access and we have like 10,000 providers that can do this and do that. Yet we're not providing telemedicine, yet we're not having a way for people to take, you know, the medication home and to use it on their own and really entrusting people that they know their bodies best. It's all about bodily autonomy, in my opinion. And one of the things too, like as you're talking, and even with the last person I was speaking with, I'm like, it's very interesting to me the parallel I see between like MAT and HRT, right? And a lot of providers are like, well, I will manage somebody's hypertension. I'm going to manage somebody's diabetes, which in my opinion is like the most complicated chronic health condition you could possibly have. Yet I won't give somebody, you know, medication for substance use disorder. I'm not going to put somebody on estrogen or testosterone because it's so complicated. I'm going to refer them to this, you know, Uber specialist, when it's like you're just shifting people around and you're not actually giving them what they're asking for. And it's only going to increase their risk, right? Their suicidality, you know, they're gonna overdose. I mean, we know how many adult learners are in the drug supply at this moment. I mean, you're seeing it just cut across all substances, all drugs that people are using. And to your point, Luke, like people are always going to be using, no matter what. You're never gonna stop it, ever.
Yeah, a lot of times, even within sometimes the field of people working or in or around harm reduction, you'll hear people start going off into the nuance of well, you know, we actually know people are using drugs because of trauma, because of this. And like, yes, there's all of these ways you could break down a million different reasons of what the actual gateway is, right? That like trauma and pain are the real gateway and all this other stuff, or lack of other medication, you know, is often. But in reality, we need to stop that right there and just stop obsessing over why people are using drugs and accept that people are using drugs and provide the mitigating factors and risk reduction things that we can, right? It's none of our goddamn business at the end of the day why someone's using drugs, unless that's something that they want to talk about and would like assistance or support with. Otherwise, it's really not up to us to be psychoanalyzing and, you know, pulling up, oh, this is about their childhood really, and if they could, no, let's look at the drug use. Look at what the positive, look at what the perceived positive, negative, and neutral effects of that drug and using that drug are, and provide whatever support we can for that person to lower their risks. And I think a lot of what you're talking about right now, especially in the federal level across the country, bodily autonomy is the topic of discussion right now for many of us, right? Understandably. And, you know, the parallels that you just drew between HRT access to MAT access. It's so true that I think the underlying factor that connects all of these things really is institutions and oppressive structures believing that they know better than what someone else does for their own body and their own mind and their own well-being. And that's just never going to create the right policy, and any policy that is suggesting you know better for someone else's body is never going to create the right behaviors and ability to act, you know, in a just way in our society. And so we really need to be, you know, I remind people all the time that when we look at changing laws to change lives, it's not just this bureaucratic words on paper. You know, it's a piece of legislation is a moral document. You know, a piece of legislation is a moral document, and when we're asking assembly members and senators to sign on, we're asking them to be moral ambassadors to drive forward a more a correct narrative and a necessary narrative that humans matter, that humans who use drugs matter, right? That people, regardless of their gender, their sexual orientation matter, people who are incarcerated matter, people living with HIV and AIDS matter, and that if we can actually accept that and embrace that, then none of this other policy would be allowed or make any sense, right? Because we just need to stop it right at the beginning of the idea that we know better for someone else than they do for themselves. People who use drugs have been keeping themselves alive for so long and keeping others alive for so long. We are the first responders in this overdose crisis. We are the ones looking out for each other, and when the state doesn't provide what we truly need, we're the ones who keep us safe. And so that's why we'll be the ones to decide how we move forward in an equitable way.
So true. It's like when you talk about that element of what we hear a lot of people in the community say, like our communities are the ones that keep us safe. Like us and only us keep us safe, right? Like when we do our like Narcan or naloxone overdose response and prevention trainings, we talk about and harp on the fact that like, people who are using drugs, people who are injecting drugs, when they're trained with Narcan, they're going to be the ones like 9 times out of 10 responding and reversing an overdose. Like that's a very real statistic, and that's a very real thing. So one of the things we talked about in the beginning was your work with Vocal, and I think since we are talking about MAT, can you just talk a little bit about the decrim legislation and like what that would mean for people? Because I think a lot of folks don't know right now that like if you're walking down the street with some butte, like you can get arrested for it and it has serious consequences.
Absolutely. So right in line with the fact that MAT, medication-assisted treatment or medication as treatment, like buprenorphine, also known as Suboxone, Subutex, Zubsolv, other pharmaceutical names otherwise, is a life-saving medication. I just want to start there with so much evidence showing how successful it is as a medication, right? Like incredibly high success rate for helping people remain in remission. And I think that just needs to be stressed in the first place. And so in line with that being not readily accessible, that there's all of these barriers that if you are consuming other drugs that either that the provider will, not prescribe the bupe because of, that they say, okay, you're using drugs, they'll decide that a drug test having certain things in it will mean that you're disqualified, right? All these reasons that we can't access bupe through legal channels leads people to quote unquote diversion. So folks needing to buy, sell, or trade, prescriptions that are not theirs with others, right? So there was actually a sign at a rally a few weeks back that said, good friends share their subs, which I really enjoyed. But I mean, it's true when you look at the most vital versions of mutual aid, it's mutual aid that's not legal often, right? Like a lot of times the mutual aid that really saves lives is mutual aid that's illegal, unfortunately. And we really need to change that, because when mutual aid is taking place, it is because the state is not providing what people need and deserve. If our needs were met, we would not be relying on mutual aid to the way in which we are in 2022, right? And so people being criminally prosecuted for accessing bupe that is not theirs, when there is not the state going, hey, but we're giving it to you so easily, you don't have any reason for not getting it. Like, okay, maybe if bupe were free, being driven around in bupe buses, given out, without any barriers, no New York State ID required, and just being given away on a bus driving around every city 24 hours, then maybe I understand them being so upset about diversion. But the reality is that if I, with health insurance, a college education, a background in harm reduction, navigating substance use treatment field, all of these things, as a white person who has money, a home, a car, all these things, if I cannot access bupe safely and consistently, then that tells you a lot about how horrendous the access is. And so what the bupe decriminalization does, it's a New York State piece of legislation. It's the number in the Senate is 2524, the number in Assembly is 612. And this bupe decriminalization bill makes it so that people cannot be criminally prosecuted for buying or selling Suboxone that is not theirs, for having Suboxone in their possession that is not with their prescription. And this is a vital step towards rectifying the wrongs of the drug war, right? We're not just talking about a public health intervention. We're talking about, and largely when we talk about public health interventions relating to drug use or overdose, we're often brushing up on the reality of the drug war, the devastation of the drug war, of the fact that this country and people running this country and the state took it upon themselves to criminalize, demonize drugs, to be public enemy number one in 1971. Our incarceration rate went up 100% since then, from 20,000 people incarcerated to over 200,000 between 1971 and today. That is not an average amount of increase. That is an increase that is intentional, that people sought out to criminalize and prosecute people for using drugs, but not just people, Black, Brown, Latinx, and Indigenous people for using drugs, while white counterparts were doing the same thing blocks away. When crack, epidemic happened in the 80s, there's white people smoking crack or snorting cocaine, but also smoking crack on Wall Street, buying and selling their stock all day. Meanwhile, Black people in the South Bronx and Brownsville were getting arrested constantly, right? Well, so the consequences of that continue to show up today in our legislation and the way that our laws look, and the fact that a lot of times people are being stopped. Finding a Suboxone wrapper in the car suddenly becomes a way for them to search everything. Also, it becomes a way for them to then look around to see if there's, somewhere that they can find a syringe with contamination in it, and then start looking into possession of the 7th charges. And it's really a horrendous pipeline to prison that needs to be removed, because we know that in terms of saving lives, which is what I hope everyone is trying to do when we're looking at the overdose crisis, and I'd really love if people would admit that they're not trying to do that when it comes to the people trying to fight things like decriminalization of BUP or trying to criminalize BUP, is that it's an immediate way to put someone into the process of being incarcerated, which is setting them up to overdose and or die. Immediately off the bat, if you want to find a real quick way to accelerate someone's likelihood to overdose and die, arresting them or putting something on their record, to bar them from employment, to sever any family ties that they have existing, to do all of those things, it's hurting our families. It's also taking parents away from their children. And we need to think about that when we're thinking about incarceration. It's not just getting that drug user off the street, quote unquote. It's taking a father, mother, child away from their family. And so decriminalizing BUP is going to be vital in reducing overdose rates, making sure that people are not being persecuted for keeping themselves and their loved ones alive when the state's not taking care of us properly, but also making an acknowledgement about this systemic attack on Black, Brown, Latinx, and people who use drugs for all of these years, and to say, hey, along with our process of decriminalizing syringes, we're also going to take this next step, because we know that we can never arrest our way out of this overdose crisis.
I love that quote, and ending on that. I love that. We need to put that on a banner, right? We can't arrest our way out of it. And I love too that you put the focus on, talking about yourself, your own experience, the privilege that you have, right? And being very hyper aware of it, and how this particular piece of legislation is really going to provide much more access and kind of take a lot of the undue burden, right, on Black, Brown, Latinx folks. And because we know time and time again, whether it's data, news articles, the numbers come back tenfold, and you can very clearly see just the way that it's completely cut through those communities, and how the needs of those communities are vastly different, and we have not been properly responding. And instead, it makes me think of like the whole Ban the Box initiative too. I think Maryland, I just saw a great video this morning that Marilyn Reyes was in, talking about, her own experience and the experiences of others. And it's ridiculous. Like, you're filling out a job application, you're looking at it, you're like, okay, well now, if I don't check off the box and I do have this on my record, they're gonna find out my background check and me putting it on it, I won't get a call back. It's something like 2/3, I think they were saying in the video, like 2/3 of folks, it inhibits their ability to get a job. And then you have to juggle. Then if you're already struggling, right? We know what works, right? So to your point, it's extremely intentional. And I think even in our first conversation too, you talking about how MAT, we're so behind when it comes to meeting people's needs, and we're stuck in this very archaic kind of model of people being able to access treatment. And I think one of the next things would be great to talk about is your work with Next Distro, because Next Distro over the past couple of years has really come into the fold, and being able to provide, harm reduction supplies to folks, connect people with resources. And I really see that being a huge portion of the future of harm reduction, and talking about mutual aid and what that really means, and your role and why you went to Next Distro, or what that interplay is. I think that folks would love it.
So at Next Distro, we are a national harm reduction based organization that is male based, right? So a male based harm reduction organization providing everything from safer injection supplies, safer smoking supplies, safer snorting supplies, and other forms of risk reduction tools, also condoms, lube, everything that you can really think of in terms of mitigating risk when it comes to drug use. And so really one of the most incredible aspects of it is, like you were just saying, Taylor, is that we're very behind in a lot of our service delivery or service provision, and also our response to the nature of overdoses in this country. And so we see, according to data, that the leading number of overdoses are not strictly a result of opioids, right? A lot of times, especially in 2020, 2021, we're seeing that it's often polysubstance use, whether intentionally or not, right? Sometimes maybe someone was using methamphetamine that had fentanyl inside of it, or MDMA with fentanyl inside of it, but also people that are polysubstance users, which is a lot of the time, people who use drugs use more than one substance. So with polysubstance use, we're seeing overdoses that are often crack cocaine and heroin and fentanyl, or opioids and fentanyl, benzodiazepines and fentanyl, other stimulants that are adding the overdoses to look different. These days, we're seeing a lot more cardiac arrest paired with respiratory suppression when someone has an overdose, right? And so even in terms of the way that our overdose prevention trainings need to be changing and updated constantly is different, right? Even our fentanyl test strips training needs to be updated constantly to adjust to sensitivities of different drugs, whether you need to use extra water when testing MDMA and methamphetamine, right? And so one of the things that I really love and I'm so proud of that we do at Next Distro is that we provide harm reduction supplies for other routes of administration besides only injection, right? So we have safer smoking kits that include things like cards, so you have a sterile surface area, pre-cut straws, so that you're not risking hepatitis C or COVID by sharing a $20 bill or dollar bill with someone else to snort a substance. Also like a little plastic razor blade for everything that you need for, consuming drugs intranasally in a safe, sterile way to mitigate risk for hepatitis C, HIV, COVID. And also, and of course, in every package, you have your Never Use Alone hotline cards, a way to access, support as well, peer support. And then also the safer smoking is one of the things I'm really, really passionate about. One of the things that I try to bring to a lot of conversations around harm reduction, whether it's in person or on Zoom, is to talk about whether we're properly responding to people who smoke drugs, that people who are smoking crack, people who are smoking meth, and are we talking to people about smoking heroin or fentanyl, right? Or fentanyl, because that is a really important thing. And also knowing and talking about routes of administration is a life-saving conversation to have with your clients, participants, friends, that knowing that if someone does take something orally instead, it's going to stay in their body longer and it's going to be a much lower risk of overdose a lot of the time, right? But also, when it comes to smoking heroin and opioids, which is why I'm so excited about it, is that it's a way for people who are seeking a more rush-like sensation of an instant gratification type feel that they might get, where you have kind of the most of that sensation when you're injecting. Then typically what folks are used to is having the most of that sensation when they're injecting, and maybe the least of that sensation where they're taking something orally, and then maybe a medium line by snorting it, right? Kind of a closer, but not as great as injecting type of rush. Now, smoking is a way to be more of a rush than snorting it, but not as much of a rush as injecting, and not as much of a risk of overdose as injecting. And so that's a crucial part of this, is that folks are consuming heroin, fentanyl, opioids, et cetera, in a smaller amount at a time. It's an easier way to test the substance, so folks are more likely to smoke a little bit rather than folks being likely to do a test shot. So even your your harm reduction spiel that you give folks around smoking, you have a lot of opportunities to talk about different methods of risk reduction, ways to be safe. And it's also, again, anytime you're bringing up the conversation, it's okay. Also, if you want to talk at some point about then going to shifting to snorting at some point or shifting to orally, let's chat then. But if not, that's okay too. But really also that and providing access to things like meth pipes, it's what only makes sense. Right now, we are in an overdose crisis, not an opioid epidemic, and not even just really an overdose crisis. We are in a drug supply poisoning crisis, right? That it's not merely about people dying. That is not the only negative thing that's happening. It's also awful that our drug supply is being poisoned and that people who use drugs can't safely know with confidence what's in their supply. And whether someone's life is being threatened or not, we all as humans and people who use drugs deserve the right to know what's inside of our drugs as part of our own bodily autonomy. And we deserve the right to do whatever we can to test our drugs, to mitigate our harm in the process, right? And so we really need to be, and I want to encourage everyone to look at their internal organization's approach to drug use and ask yourself, is it comprehensive? Is it expansive? Are you having conversations with people about smoking meth, about ways to make sure that they're not using broken pipes for that either? Are you providing safer smoking kits for smoking crack? A lot of this drug use also increased during the pandemic and due to changes in the drug supply. So people who didn't smoke crack or meth years ago are now smoking it. I know myself personally, when a lot of the changes occurred with the drug supply and there wasn't as much heroin around anymore, that contributed to how I ended up personally using things like meth and crack at different times when I hadn't ever in the past. And so there's been cultural changes from the drug supply as well as the chemical changes. And so we really need to be constantly updating the way we respond and fighting to say, hey, we need funding for these supplies also. So we need to be encouraging the AIDS Institute and other funders to be like, hey, this is an overdose crisis and a drug poisoning situation. We need funding for safer smoking, for safer snorting, and every other form of mitigating risk for people who use drugs.
Oh, Luke, this is so real. Oh my gosh, this conversation go on forever. You said so many things, so many gems. I would have banners up everywhere if I could just pull quotes from this. But one of the things that you just said too makes me think of a tweet that I saw from Next Distro, and I'll read it. It's May 5th. So far this month, Next received 47 opioid overdose reversal reports across 18 states. 36% of reversals came from unfunded program partners. Imagine what we could do if harm reduction was funded and naloxone was plentiful. And I think that speaks volumes. And it also makes me think about, you talking about that shift from heroin to things like crack and meth, and how the stigma with meth and crack is very different than the stigma associated with, things like heroin or even fentanyl, right? And like a lot of what we're seeing now too is like this almost diversification with meth. And I focus on that because that for me has been like a big source of people asking for trainings around like chemsex, party and play and things of that nature, and how we're seeing a lot more deaths related to the drug poisoning associated with things like meth. And not a lot of people are talking about it, not to diminish anybody's work, but I think we also know why we're not talking about it, because if you look at the communities that are directly affected by it, we're seeing a lot of young Black and brown gay and bisexual men, and when we talk about it, we talk about the drive from the white community, really bringing it into the Black community and really just decimating queer life, gay culture. Talk about things like Ed Buck, who recently just got put away for 30 years for what he did, killing multiple young men. But I do want to wrap this up and give you time for any closing thoughts. I think everything we've been talking about with Next Distro and Butte Decrim, your work at Vocal, like, where do you see in the next 6 months to a year, where do you see things really landing? I know if you had a crystal ball and you can kind of look into it, what's your kind of gut check here of where do you think this work is going to drive to next?
So I think that we are seeing already that we have a lot of momentum around the Safer Consumption Services Act and BUP decrim already, and more than I think some people realize that. And the fact that we have overdose prevention centers in New York City functioning right now, while it's partially out of civil disobedience at the federal level, which it needs to be sometimes for change to happen, I believe we have the knowledge, resources, and the fight within our movement to pass these bills this session, potentially. And if we don't, we have the movement and the momentum and the experiential authority within our statewide users union and our national efforts to fight to end the drug war, that we will advance these campaigns to the level where we're able to completely pass them in 2023, if not this year. Because every session, even if it's not an immediate win, it's building that case for that following year to make it happen. And I believe that harm reduction is absolutely not simply a form of service provision or of a way to respond to drug use. Harm reduction is a movement, right? Harm reduction began as a movement and is meant to be continued as a movement, regardless of how much we normalize it as a form of service provision or a style in which we want to use. It is a people-led movement that needs to continue to center the people. And I really believe that the more people who come forward to share their stories about lack of access to MAT, about how much even their own counselors understood that they needed to access BUP through, through other friends and non-legal means just to get by, and that is so common that even counselors at clinics say, I understand if you need to buy your strips until you can see our doc. That is a common thing to occur. That was even happening in 2014, and it is still happening today. So I really believe the more people who come forward and share and understand that you don't need anything other than your own experiential authority and a passion to get involved in this work. You're the expert of your own life. And I really recommend that folks get involved, reach out to an organization, reach out to, look up the Drug Policy Alliance, look at what's going on in terms of the harm reduction movement, drug policy overall. Also reach out to organizations like Vocal New York, like Housing Works, like the Harm Reduction Coalition, LAC, and others, and get involved in this work, because we need people who have been impacted by this to come forward and talk about this. And the more we do, the more we drive these bills forward. But I also believe in the next 6 months, not only are we going to advance these bills on the legislative campaign, we are going to shift the narrative on a national and a statewide level, but certainly also on a national level, to be building back the dignity and autonomy of drug users everywhere, and really continuing to build a narrative that says that this is not simply, it's not just something that the mass public is going to accept because they think, okay, it's a disease and we can rationalize it that way, but they're going to begin accepting it as a cultural behavior, as a part of life, as a part of behavior that will never be prevented by saying stop. And so I believe that we need to keep talking about it. We need to keep pushing to get things like Narcan test strips and everything into bars and restaurants and everywhere, but also, of course, be pushing within the movement to ensure that we're responding to a polysubstance form of drug use, that we are responding to the drugs supply being poisoned across the board, with all substances being impacted and not only opioids, and that we'll continue to find creative ways to work around not having funding for those things, but we need to make sure we're fighting for that funding in the process. And so I feel optimistic and hopeful that while we've been very stuck in a static place for a while, saying, okay, we've got test strips in Narcan, we're good, that we're going to push ourselves beyond this precipice and really say, we know we need and deserve more, and we're going to get it.
Period. That's it. Luke Grandis, folks. That's that on that. And it's interesting too, like whenever we talk about, how dynamic people are, I always remind people, like, and people's drug use is just as dynamic, right? And we have to really meet those needs. And also, to not to be corny, but like to your point, we need to keep talking about this, because it's like when we do rescue breathing, right? You have to keep breathing life into that individual. You have to keep breathing life literally into this movement, because if we don't, there's not going to be any of us anymore. And that's the reality. We've already lost too many people.
yeah, we need each other to keep this fight going. And so we've really got to do everything we can, even if it includes mutual aid at time, but we've got to stop. We can't stop putting it on the state to
because it ain't working. It hasn't worked. So
right.
Well, thank you so much, Luke.
Of course. Thank you, Taylor. I really appreciate it, and appreciate that you're telling our stories, helping us tell our stories.
My pleasure.